We'll also proceed to the next symposium on metabolic dysfunction associated steatotic liver diseases. May I please invite the chairperson, Dr. Katie Shenoy, Dr. Meena Bansal, and Dr. Divya P. Kumar. I will also take the honor to invite the speaker, Dr. Harmeet Malhi, on pathophysiology of MASLD, recent concepts.
Good afternoon. Thank you to all the organizers, Professor Duseja, Taneja, Theeman, for the opportunity to talk today on the pathophysiology of MASLD. I'm extremely grateful that I don't have to follow Professor Sanyal because that is a really, really difficult task. Here are my disclosures. None are relevant to the content of this talk. And my slides seemed, okay, here we go, learning objectives. We'll talk about lipids and lipotoxicity in MASLD and MASH. We'll talk briefly about sterile inflammation in MASH, and then the roles of lipotoxicity and inflammation in fibrosis progression. We know that adipose liver crosstalk changes from health to obesity. In health, shown on the left, the adipose tissue performs its depot function and does lipid buffering. This is highly regulated by hormones such as insulin, glucagon, and adipokines. And the adipose tissue is quite flexible between fasting and feeding states. Whereas in obesity, the adipose tissue is dysregulated, there is an altered insulin response, aberrant adipokine secretion, there is a spillover effect of free fatty acids from this dysfunctional adipose tissue. The adipose becomes inflexible and inflamed. Another important point I would like to make is that adipose expansion does not equal adipose dysfunction. Adipose can be dysfunction in many other disease states. We heard from earlier speakers about lipodystrophy, and as you can see, a liver biopsy on the left from a patient with lipodystrophy also has the cardinal features of a MASH liver biopsy, which is shown on the right with ballooning, inflammation, and micro and macrovesicular steatosis. So what are the consequences of this adipose dysfunction? It's well known now that healthy adipose tissue can mitigate MASH. If we look at this cartoon, this is a representation of normal adipose tissue, but in unhealthy adipose expansion, there is adipocyte hypertrophy as well as an accumulation of pro-inflammatory macrophages. We know from many clinical trials, such as with the PPAR gamma agonist pioglitazone and the pan-PPAR agonist lanifibranor, that adipocyte hyperplasia and associated weight gain are associated with MASH resolution or mitigation. These are some data from the PIVENS trial that really illustrate this point. In patients that are on pioglitazone, there is a reduction in AST levels, there is an improvement in insulin resistance, yet there is weight gain. So all of this to make the point that adipose function or mitigating adipose dysfunction is important in ameliorating MASH. What happens in insulin resistance in adipose tissue and in the liver? There is increased lipolysis in the dysfunctional adipose tissue. And in a liver in insulin resistant states, there is increased de novo lipogenesis and a failure of suppression of hepatic glucose production. And all of this ends up resulting in a lot of free fatty acid delivery to the liver. This slide shows us what the sources of free fatty acids are that contribute to liver triglycerides and MASLD. So a vast majority comes from the dysfunctional adipose tissue. Some of it comes from dietary sources, and about 25% comes from de novo lipogenesis. Remember that this number is about 5% in the absence of insulin resistance and obesity. So there is a significant increase in de novo lipogenesis and a significant increase in delivery of free fatty acids from dysfunctional adipose tissue. Other than free fatty acids, many other bioactive lipids are implicated in MASH progression. On this slide, we illustrate that a healthy liver state is associated with healthy lipids such as resolvins and omega-3 polyunsaturated fatty acids, whereas the MASH state is associated with unhealthy lipids such as saturated fatty acids, lysophosphatidyl-choline, ceramides, sphingosine 1-phosphate, and free cholesterol. There are some data that support that taking away fat takes away the source that leads to the inflammation, so putting out the fire. And I'm a big fan of this study because it really illustrates the case well that bariatric surgery provides long-term resolution of MASH and regression of fibrosis. This is their graphical abstract. It's a little busy, but if we go from left to right, we'll look at resolution of NASH according to weight loss. And the greater the BMI loss, which is shown here on the x-axis, there is a greater resolution of NASH without worsening of fibrosis. So a BMI loss of greater than 10 kilograms per meter square, 90.5% of patients have a resolution of NASH without worsening fibrosis. The middle brown graph demonstrates the improvement in fibrosis in the same patients, moving from baseline to 1 year to 5 year paired biopsies. And then the photomicrographs on the right are to illustrate the histological resolution of MASH and fibrosis after bariatric surgery. Similar data are also now emerging from the pharmacological weight loss studies with semaglutide on the left, tirzepatide on the right, and you can see MASH resolution in these studies is really significantly associated with weight loss, which was significantly greater as predicted in patients that received the GLP-1 agonists compared to placebo. So, what do lipids do? Lipids such as saturated fatty acids and sphingolipids activate cellular stress and cell death pathways. A lot of work in the last 15 years in my lab and in the lab of others have defined that saturated fatty acids such as palmitate can lead to ER stress, can lead to lysosomal permeabilization, mitochondrial dysfunction, and cell death. A new kid on the block that's interesting to many is ferroptosis. This is an iron-catalyzed peroxidation of polyunsaturated fatty acids in membrane phospholipids. And while there are no direct data implicating that oxidized phospholipids are increased in the plasma membrane of MASH patients, there's a lot of correlative data that lipid peroxides are increased in these patients. And there is also no data that this form of cell death is immunogenic. So more to follow in this space to try to understand what is the true contribution of ferroptosis towards MASH and whether ferroptosis may be a therapeutic target. My lab has also demonstrated that lipotoxic ER stress can be communicated by hepatocytes by the release of extracellular vesicles. This cartoon summarizes our mechanistic work demonstrating that palmitate activates the ER stress response, leading to the release of ceramide and S1P enriched extracellular vesicles, which our group and many other groups have shown can then have local effects in the liver by affecting hepatic stellate cell activation, endothelial cell dysfunction, immune dysfunction, and distant effects in adipose tissue and bone marrow. Continuing to talk about inflammation and examining the role of extracellular vesicles that are enriched with sphingosine 1-phosphate, our lab has shown that myeloid cell sphingosine 1-phosphate signaling can influence the immune cell infiltration and sterile inflammation observed in MASH. And we have shown that when S1P receptor 1 is knocked out in macrophages or monocyte-derived macrophages, there are secondary changes in the inflammatory tone in the liver being reduced. There's a lot of emerging work in this space to try to understand what are the stimuli that activate the sterile inflammatory response, and some very nice recent studies that look at B cell receptor signaling and pyruvate metabolism, and even bacterial components in their role in activating B cells in MASH. Oxidized 40L, which is an oxidized phospholipid ligand and its receptor in CD4 cells, extracellular ATP and acetate in autoaggressive CXCR positive cytotoxic T cells. Not a lot of data on dendritic cells because they are a professional antigen presenting cell and hard to understand what their role in sterile inflammation may be, but really a theme here is immunometabolism and metabolites that directly impact the sterile inflammatory response in MASH. Palmitate can have direct effects on inflammatory signaling. Shown here are some data from macrophages and hepatocytes indicating that lipids can directly cause pro-inflammatory signaling. And then some data here that the transcriptome of intrahepatic leukocytes can really be used to examine the gene pathways that are upregulated in dietary models of MASH. And in this case, we used a RAGE antagonist, but when we antagonize inflammatory signaling, the improvement that we see is in the top pathways that are known to be functionally activated in MASH. We'll skip over this slide because I think I have 3 minutes less than I thought I did, and we'll talk about genetic modifiers of lipotoxicity. This is important to understand because trying to understand how patients with MASLD may declare themselves to either have MASL or MASH really does remain an unanswered question, and we understand that genetic modifiers may play a role in steatosis, in progression to steatohepatitis, and fibrosis progression. I wanted to use the last minute to talk about the microbiome. I'll skip over this didactic slide to talk about two recent studies that are very intriguing. This was published in Cell in 2024, and they discovered a novel secondary bile acid using a click chemistry-based approach. They then found that Bacteroides uniformis forms this bile acid. The bacteria and the bile acid are depleted in humans with MASH when artificially replaced by either colonizing by the bacteria or providing the substrate. They lead to a healthy microbiome and restoration of akkermansia and a mitigation of MASH. Very nice mechanistic study linking a bacterial metabolite to MASH pathogenesis. And another very recent interesting study is on a fungus, Fusarium fetans, that was identified in fecal samples in China using they call it phi-chip-based method to identify fungi in feces. And this particular symbiont gut fungus decreases host ceramide via formation of this metabolite, FFC1, which in turn also mitigates or ameliorates MASH by inhibiting intestinal ceramide synthase. So a lot of exciting work in MASH pathogenesis. So I will end by key takeaways that MASLD is a systemic disease where adipose tissue dysfunction is central to the development of hepatic steatosis. Lipotoxicity is a key pathophysiological process that triggers the sterile inflammation, which is a hallmark of progressive MASH. And it is likely that the local milieu in the liver separates MASL from MASH, which has injury, inflammation, and fibrosis. Thank you. Sorry, I misread the timer because my screen says oops, and I was told I have 2 more minutes, but since I skipped through slides, we'll just gain the 2 minutes and move on to Professor Sanyal.
Okay. Can I have my first slide, please? Start?
Yes.
Okay.
You have 2 extra minutes.
So thank you very much. And so my task is to review quickly in 15 minutes the current and future pharmacotherapy of MASH. So once again, here are my disclosures. So I want to continue to build on the theme that has been discussed multiple times, that MASLD and its aggressive form, steatohepatitis, is not a disease that lives in isolation, but is a critical element of a cluster of disorders that are considered metabolic disorders, and metabolic ill health linked to cardiovascular disease, type 2 diabetes, NASH, chronic kidney disease, really represents an existential threat to the human race, where we move from a healthy to a metabolically unhealthy, primarily characterized by adiposity, as Harmeet showed beautifully, to clinically silent and then clinically obvious disease. Now, we've been focused on developing guidelines for one organ at a time. You have cardiovascular guidelines, you have the liver guidelines, you have diabetes guidelines, kidney guidelines. And while we are making all these guidelines, life expectancy is declining in all age bands. And this cluster of disorders account for 70% of premature deaths worldwide. That's about 40 million deaths annually worldwide. So our report card doesn't look very good. So what are we doing currently? Our current approach really is focused on reducing end organ disease burden. So the hypertension people have very nice guidelines for managing hypertension, but they ignore everything else. We have similarly goals and aspirations for how we manage diastolic dysfunction, type 2 diabetes, chronic kidney disease. From a liver perspective, our goal is to prevent cirrhosis, reduce decompensation, prevent hepatocellular carcinoma. What we are not taking into consideration is that all of these different disorders are frequently present in various permutations and combinations within the same patient. And they represent competitive risks to the patient, where all of these are trying to kill the patient. If you put a shield against one and not the other, the net result frequently does not change. So what connects all of these conditions is underlying metabolic stress that is linked to diet-induced obesity. And so our current approaches are listed over here for the different end organ diseases, but you'll see something that is common across the board is weight loss. And I'll start that over there as our starting point for conversation today. So most people and all of the guidelines from the liver societies focus on people who have started scarring down their liver because they are at greater risk of liver-related outcomes. And now I would try to propose being a little disruptive, a little controversial, but for sake of conversation, a sort of a risk-based approach that covers the entire population. So if you look at the population pyramid of everyone who has MASLD, at the bottom are people who have early disease, fatty liver, steatohepatitis, fibrosis stage 0 or 1. They have a low FIB4, their liver stiffness is below 10, their ELF score is low. And the main cause of death here is cardiometabolic and cancer, but we know biologically the liver disease is contributing to the cardiovascular disease and diabetes in this population. So let's ask the question, if we wipe out steatotic liver disease at this point when it's very easy, will it prevent more advanced disease down the road? Why do you have to wait till somebody gets advanced disease? So with the new class of GLP-based therapeutics, we can see that with effective weight loss, up to 80 to 90% of patients can completely defat the liver within 6 months, and this is sustained for at least the data so far we show is for 1 year. So it shows that with effective weight loss, no matter how you do it, you can actually defat the liver. And when you look at population-based data on people who had type 2 diabetes and received GLP-1s, regardless of which one they got, over time, there's a progressive disparity between the control arm, which did not get GLP, and the treated arm. in terms of absolute risk of liver-related events as well as mortality. Remember, these are all people who had very early liver disease. So it may take 10 years to really see a big difference, but the longer you go, your control arm is now getting more liver disease, they're getting more liver outcomes, and the benefits of GLP-1 start becoming more obvious. So I would propose that even very early on, the fact that somebody has fatty liver, most of these people have other risk factors. In order to benefit, so many of them already have established indications for cardiovascular and diabetes and other things to get a GLP-1, but this is a population that really effective weight loss early on may be beneficial, and it'll cut the tap off, where you're seeing this growing burden of people who are coming with advanced disease. It's like treating hepatitis C. You treat the root cause, the people presenting with more advanced disease will decrease. Now, of course, the bulk of the data that we have is in the middle of what we call at-risk MASH with people who have F2, F3 fibrosis. They've started scarring down their liver. They have increased all-cause and liver-related mortality. And there's a list of drugs on which we have really quite a good amount of data. And the goal here is to prevent cirrhosis and to improve comorbidity-related outcomes. Because remember, competing threats, it's not just the liver disease. It's the heart disease, the cancers, everything is out to get the patient. And your job as a doctor is to save the patient, not just the liver, even if you're a specialist. And now we have a good paradigm for how the disease develops, and Harmeet showed this very nicely with the metabolic stress, with the lipotoxicity, injuring the cells, producing sterile inflammation and fibrogenesis. And there are now targets that are available for all of these different steps in the biological cascade that allows disease development. So starting with the oldies but goodies, you have pioglitazone and vitamin E. And you know, one thing I want to point out, everybody says vitamin E and pioglitazone affect fibrosis. So in these studies, it did not hit statistical significance. But remember, statistical significance is a function of the effect size, that is the difference between your placebo and the treatment arm, and your sample size. So for a given effect size, if your sample size is big enough, you will get a p-value. So in these early studies, like the PIVENS trial, where there were only 70 patients in each arm, it was underpowered to pick up a small 10% placebo-corrected difference in fibrosis. But the actually trend line, if you see that blue horizontal line, there is a 10% placebo-corrected fibrosis benefit. And of course, across meta-analyses also show that there is fibrosis benefit. So, you know, I would completely discard vitamin E right now because it's something that costs pennies, and in very resource-constrained areas, it may have a role. But there are better drugs. And in India, we're very fortunate that we have saroglitazar, and the Indian phase 3 program was the basis for its approval. Many of you have used this extensively. You have more experience that I've only used it in the setting of clinical trials. You guys use it every day in your practice, so you know this better than me, that it is a drug that is very effective in improving the dyslipidemia, so it should help the cardiovascular profile. It has been shown to improve fat in the liver. It has been shown to improve NASH. Very small data from our center where we looked at biopsies and actually found some improvement in biopsies. There's a big phase 2b trial with 160 patients that has been completed. We should have a readout by early first quarter of 2026. And that will be really very, very important to further solidify the role of a drug like this in the treatment. Now, what is available to us in the West is resmetirom, which is a thyroxine beta receptor, works by making the liver burn off the fat, improve mitochondrial health, reduce oxidative stress, and reduce the injury inflammatory drivers of fibrosis. And you can see over here again that it is better than placebo in producing fibrosis improvement. It's a very well-tolerated drug with some early diarrhea, but it usually resolves. Most recently now is the ESSENCE data with semaglutide, which is a GLP-1, and it shows 62% NASH resolution, almost a doubling of the placebo-corrected response, and again, a 15% placebo-corrected improvement in fibrosis. This drug is likely to get approved in the next few months in the US, and of course, it has been established to show benefit for cardiovascular, diabetes, kidney, and sleep apnea, and several other things. Now, the future. The future are FGF21s. So GLPs are already here, saroglitaz are here, lanifibranor will read out, which is a pan-PPAR agonist, probably by next year in phase 3. But the future really, I believe, are the FGF21s. And these are the data that were presented last year. It was published in Lancet Gastroenterology. And at the end of 2 years, you notice 75% of patients with stage 2 or 3 disease had fibrosis regression. So that's 3 out of 4 patients actually had fibrosis regression. And when we talk about NASH, fibrosis is really where the rubber meets the road. You know, if you don't have fibrosis improvement, you don't really have an effective MASH therapy because it is fibrosis that drives prognosis. If you don't improve the fibrosis, you probably don't have a drug that is going to be competitive in the market space. But to get 75% fibrosis regression really is a fantastic, dramatic finding. And it is in phase 3 right now. And of course, these phase 2 data will need to be confirmed. It also teaches 2 other things. First, that it is a long game. Everybody is in a rush to find their answer in 6 months. But MASH progresses to cirrhosis over a period of decades. It is a long game. And if you wait 2 years, you got the 75% response. Number 2, you see in the middle of that dark blue panel on the right, there's a white line running through the middle of the bar. That's how much the response rate was when they studied it at 36 weeks. So if you go early, you find a response, but then there are additional people. So they're late responders. It's not that what you see at 24 or 36 weeks is what you have for the rest of life. There is an incremental response. You have to stay the course with effective drug. So I think this is very, very important in the design of studies going forward. And these phase 3s are going to be very important, along with second generation GLP anchored molecules, such as tirzepatide, which is GLP-GIP, and survodutide, which is a GLP glucagon. There are multiple other GLP glucagons in play as well. And then, of course, there's lanifibranor. And then beyond that, in the future, we're going to see combination therapies. So these are very early data from efruxifermin from the phase 2, where there were some patients who were already GLP experienced coming into the study. And you found that in these GLP experienced patients, the addition of efruxifermin really added to the benefit, whereas in the placebo arm, these patients really did not change that much. And both in terms of the proportion of subjects with normalization of liver fat, shown on the panel A, and then the proportion of people whose liver stiffness improved. And you can see it's a dramatic liver improvement in liver fat over here. So there's some early data that combinations may work. The future is going to be precision. You know, we've already got data that even though the biopsy looks the same, at a molecular level, there are distinct clusters of patients. And there are already programs for people with PNPLA3 mutation to silence it. There are programs to silence across the board all patients with HSD17B13. So genetic-based and precision medicine is coming. And of course, when you talk about the people at closest to outcomes, the cirrhotic patients, high FIB4, they've got features of CSPH, and these are on the most at-risk population. These are really in the realm of the hepatologist. We're on the verge of a breakthrough. These are the most recent data with efruxifermin, FGF21, and we'll talk about it a little bit more in this session later today, but you're seeing 39% fibrosis regression in the cirrhotic population. So that is pretty dang good for a drug in the NASH space to actually provide this kind of response. So this was published in New England Journal recently as well, and I believe is very exciting, moving into phase 3 again. And if you look at the current landscape, we have the resmetirom approval, semaglutide expected approval, lanifibranor will read out. Then we have efruxifermin. There's a whole bunch of additional molecules coming down the pike. And then there's a denifanstat. There's a typo here. Pegozafermin is not a GLP glucagon. Pegozafermin is a FGF21 molecule. There's survodutide. And then, of course, there's denifanstat, which is a fatty acid synthetase inhibitor. So very, very active pipeline. The molecules are looking very good. And in the future, if we really want to dream, Instead of waiting for people to have clinically obvious disease, we need to really start thinking about making the population metabolically healthy early on, identify when they are metabolically unhealthy, but their organs are intact, and target these people to prevent the development of obvious disease rather than put a Band-Aid on organs that have already been damaged. With that, I stop. Thank you for your attention.
Thank you. Any questions? Any questions from the audience? We have a Q&A session now. I'll start with a question. In the cirrhotic patient, we know often you lose fat. You don't see fat on biopsy. I'm aware of autocrine signaling pathways with stellate cells, but to what extent do you think lipotoxicity still plays a role in driving the disease?
So I think the question is, in patients that are cirrhotic and there is loss of fat, is lipotoxicity still playing a role in driving the disease?
Go for it.
Yes, I think, Meena, you answered part of the question yourself, and we know this also from patients with viral hepatitis B and C in particular, where in spite of DAAs, which is complete etiological reversal, there are patients that will continue to have fibrosis progression. So arguably, the horse has left the barn. There are activated stellate cells, and it is also the scenario in which antifibrotic therapies are most likely to be effective, as opposed to up to F1, where F3, where etiological reversal is likely to be more effective.
So I have a little different take on this. So our metabolomic data suggests that while accumulation of triglyceride sort of decreases, everybody knows that when you get to cirrhosis, and that's what you were alluding to, that there are still abnormalities in sphingolipids. There's a very big eicosanoid signature, and many of these are pro-inflammatory. So I think of lipotoxicity more broadly. So it all depends on how you define the word lipotoxicity, right?
Sure. I mean, triglycerides are really non-toxic.
Right.
So really depends perhaps on both then.
Yeah. So, and there are anecdotal experiences. I can only share anecdotes because it is an anecdote of actually people pulling back from the brink with GLP-1s in people on the verge who have early decompensation. I have multiple patients I've treated like that, but these are anecdotes. So that's a big caveat, not to be taken as truth at this point.
Yeah, I'm Ashish from Gangaram Hospital, Delhi. So when we see all these trials across from starting from PIVINS to Essence and so the placebo-corrected response over for the fibrosis regression has ranged from 10% in PIVINS to up to maybe 16% in Essence, and then phase 2 tirzepatide trial, it's 25%. So they all range between 10 to 15, 16%. Resmetirom is 14% over placebo. So all these are not actually reaching where we want to reach. So I think there's a ceiling. So if we combine drugs across, like you also mentioned, so why don't we see more of a combination trials in your horizon?
So I think of course, you have to think about hepatitis C, just to put it in perspective. We started with 5% response rates with ALT and worked our way. It took 20 years to get to the SVRs. And in hepatology, we're spoiled because we're used to our hepatitis C success stories. So with the efruxifermin data, where we're now looking at 75% fibrosis regression, we are actually beginning to get up there. Now, the regulatory path for drug approval requires the utility of individual elements to be established before you can combine them. So almost certainly these studies are going to come.
Okay, thank you.
Dr. Hamid, this is also Dr. Ashish. Wanted two questions from you. One was regarding the ceramides. What are the origin lipids for ceramides? If they are the PUFAs or the saturated lipids? That is one. And secondly, we have data with liraglutide that it causes some degree of fat cell hyperplasia, increasing the number of fat cells. Do we have similar data with semaglutide? So in case the patient is going to stop that semaglutide after some years, with the increased number of fat cells, are we going to expect a rebound of the fat?
So the first part of the question has to do with what are the building blocks of ceramides. The building blocks of all sphingolipids are serine and palmitate. And the first step of de novo ceramide synthesis relies on an enzyme, serine palmitoyl transferase, which is known to be upregulated in lipotoxic states. Ceramides are essential for life. There are some salvage pathways. We don't think the salvage pathways are as important in lipotoxicity as the de novo ceramide synthesis pathways. The second part of the question is also very interesting and has to do with adipogenic or obesity memory. If you look at experimental studies, and there's some human data, notably The Biggest Loser, which was a reality TV show, but in animal models, the number of adipocytes remains constant. They can expand and they can shrink, and they retain a memory of the obesogenic insult and demonstrate rebound obesity when returned to that obesogenic environment. So it is a very real risk.
Dr. Sanyal, for you, what is the real world data on semaglutide? Whether it is the prolonged duration between the two meals which is responsible for this weight loss, a sort of intermittent fasting, or it is the increased BMR which is happening in these patients? What should propose the mechanism of weight loss in patients treated with semaglutide and tirzepatide? What should be is it the decreased calorie intake because of the prolonged duration between the meals, or the increased basal metabolic rate? What do you propose?
So both are in play, actually, where clearly decreased caloric intake is a major part. But in addition to that, there is a metabolic, because they get the fat out of the muscle, so the muscle is able to more effectively burn fat as well. So you can mobilize the fat more effectively. So imagine if you stop eating, but you cannot mobilize your adipose tissue mass, then you won't lose weight, right? It'll stay flat. So you have to burn that fat off, right? So you also become more effective in mobilizing the fat by becoming more metabolically flexible.
Thanks.
So I have two questions. One, since the fat is a very important component, not only in MASLs, but also in other diseases like alcoholic liver disease or other. So those strategies can be used in them also. One. Second is fibrosis part. Fibrosis is also even in hepatitis B, C. There is a lot of fibrotic material, cirrhotics. So now that we have capability of reversing the fibrosis, those medicines should also be used in them, so that the fibrosis score comes down from say F4, F3 to F2, F0.
So, tough question. So let me take the second question first. I think in hepatitis C, what we found is that with effective treatment and cure of hepatitis C, we have, at least in my center, we've actually looked at this. We have about 500-600 cirrhotic patients that we have cured. Basically, they just come for their annual visits, and they're getting older, I'm getting older. We talk about our children. We don't even talk about their liver. They see the nurse, they get their ultrasound. And other than the occasional hepatocellular carcinoma, not much is happening. So for F2, F3, if you've cured the hepatitis C, they're probably not going to die of their liver disease. Now, it may be a little bit different for the patient who is showing some decompensation features, but you'd have to do the trials. But just because you see scar tissue and the molecule works doesn't mean how you got the scar tissue may not be exactly the same in MASH versus viral hepatitis. So you have to test these molecules in the individual clinical context.
And the first question about lipotoxicity in alcohol versus MetALD versus MASH is really a long discussion, and perhaps we can take it offline. There are certainly lipids that are conserved between the two, and there are distinct toxic lipids related to each etiology. So the commonalities can be targeted with drugs that target them.
Thank you.
Would you permit a question? My question is to Dr. Sanyal. So you said 70% of all deaths worldwide are related to this syndrome.
Not to MASH, to NCDs.
And liver disease is a much smaller component of this. And then we say those who have fat deposition in the liver should be treated as early. So why should we even talk about fat deposition in the liver? Wouldn't it be much better to just say that anybody who's overweight, obese should be treated? Why are we focusing on liver then?
Well, a couple of things. First of all, the topic of today's talk was to talk about future of MASLD.
Okay.
So
That I agree.
And that population is systematically ignored by all of the practice guidelines. And I just want to point out that ignoring a population of patients is never a good idea. You know, academic purity is one thing, but everyday patient care, we're still responsible for providing care to our patients, and that's what I was trying to point out. But I do agree, because 75 to 80% of those overweight, obese patients will have fat in the liver. It's almost like you don't need to do a test. You can look at a patient and you'd be right, 4 times out of 5. So I do concur with you.
Thank you.
So we'll close this session.